ICANS, or immune effector cell-associated neurotoxicity syndrome, is an inflammatory syndrome that is somewhat related to CRS, but it's really when that inflammatory response goes into the nervous system. And that happens when everything gets a little leaky during that inflammatory response, and some of those immune proteins and cytokines and some of actually the immune cells can leak into the nervous system, and they can cause damage and inflammation to the nervous system itself. They cross what's called the blood-brain barrier, which normally protects us from a lot of that kind of damage, and they can get through and cause damage to the nervous system itself. So we actually have really good ways of monitoring this. Similarly to CRS, there's not really a good way to prevent it. We do know that people who have a higher burden of disease, so have more cancer in their body, who get maybe a higher dose of treatment or a higher dose of CAR T cells are at more risk, and particularly older patients are also at more risk of this neurotoxicity, but we don't have a great way to prevent it, unfortunately. Fortunately, it is less common than CRS, and the severe ICANS is less common than severe CRS, so we don't see it too often. We have a great monitoring system for it, so we have ways of measuring this neurotoxicity as it develops. So in the early stages, it might be some mild confusion, some headache, but you can get more severe manifestations, which can be severe confusion, it can be seizures, and you can progress to severe swelling of the brain that can be quite serious. So we monitor in multiple ways. So we actually have a little scoring system that patients have to go through, and they have to tell you where they are, and do they know where they are and who they are, and they have to do some simple mental tasks. We also look at things like, is there any damage to how their sensation or how they move? Is there any evidence that they have any seizure activity? And that might be from symptoms that they're having or from EEGs, which measure the brain activity. Or we might be able to find signs on their assessment or on their imaging, say if they had an MRI that shows signs of swelling in the brain, and we plug all that into a score, and that gives us a grading system to tell us how severe the ICANS is. And if it's mild, we usually get the neurologist to come in. They help to guide the testing that they think we need to do early on. They might tell us if we need to start anti-seizure medication as prevention, or if we're seeing some early signs of seizure activity. So the neurologists are very helpful in guiding us with the management of this condition. And then if it starts to become more severe, again, we're getting our intensive care colleagues in the ICU involved early in case the patient needs to be transferred down to the intensive care unit. And in this case, that wonderful tocilizumab drug that we use with the CRS syndrome, we don't bring it in unless they actually have CRS syndrome. Really, for this, the mainstay to bring down the inflammation and bring down the swelling within the nervous system is steroids. And as the syndrome becomes more severe, we can increase the dose and the frequency of the steroids, and maybe even bring in other drugs to suppress the immune system if needed, if the syndrome is very severe. So it's really kind of making sure that the swelling of the brain and the inflammation of the nervous system doesn't become too severe, treating seizures, making sure that patients are in a safe environment. And again, fortunately, even though it can be quite frightening and has to be treated very aggressively, most patients do really well at the other end of it.